I'd like to introduce Dr. Niamh Ramsay. Niamh's a medical officer and an honorary research assistant at Neuroscience Research Australia. Fortunately for us at the Hip Fracture Registry, she has been working with us between 2020 until halfway through this year in 2022, and we were all very sad to see her go. She's been the leader in the social media space and particularly in the development of the registry podcast Hipcast. Niamh's returned to clinical work and is currently undertaking a Masters of Research at the University of New South Wales in clinical medicine, looking particularly at the impact of variation in management of hip fractures on patient mortality. Welcome, Niamh.
Good morning, everyone. Nice to be here in person. So today I'll be talking about a study I'm working on as part of my Masters by Research, evaluating the impact of cement fixation on mortality and arthroplasty for hip fracture. So it's been a collaborative effort with my supervisors, Prof. Jackie Close, Prof. Ian Harris, and Dr. Lara Harvey. So as mentioned, I am a current Masters by Research candidate at the University of New South Wales, Sydney. In terms of competing interests, I was previously employed by the ANZHFR through Neuroscience Research Australia. Prof. Jackie Close is a co-chair of the ANZHFR. Prof. Ian Harris was previous co-chair, and Dr. Lara doesn't have any competing interests. So today the real topic is cementing in hip arthroplasty. So what we know is that there's an increasing burden of hip fractures globally, with about 19,000 hip fractures seen in Australia each year. That's about 25,000 across Australia and New Zealand. And that's with a mortality of about 7% in the first 30 days. So 98% of these patients do undergo surgery, and that's what we've seen in Australia. And when we talk about the types of surgeries that those patients get, it really is, do they get an internal fixation or do they get some sort of replacement, so a hemiarthroplasty or a total hip arthroplasty, and that's what we're looking at today. Now, that's not the only variation. There's also variation of whether cement might be used with that arthroplasty or whether the arthroplasty continues on uncemented. And when we're looking at cement, it's really a balancing act. So when you're trying to make that decision, I guess the balancing act of potential increased mortality versus improved functional outcomes. So when we're talking about improved functional outcomes with cementing, what's been previously established is that you have improved postoperative pain, improved postoperative mobility, and reduced reoperation rates. Now, with this concern about increased mortality, there's, for those who, I guess, aren't familiar with it, there's a syndrome called bone cement implantation syndrome, whereby once the cement is implanted, you can get an emboli kind of branch off, and that can lead to a cascade of different effects. I guess leading from hypoxia to loss of consciousness to hypotension, pulmonary hypertension, cardiac arrest, and ultimately death. Now that's seen, BCIS or bone cement implantation syndrome, seen in about up to 28% of cases, but in most cases that's quite mild. Only about 1.7% of cases end up having some sort of cardiovascular collapse. So our question for this study was really to establish, okay, well, what is that mortality risk? Because there are so many benefits to using cement. So what mortality risk are we dealing with in the Australian population? So to do that, we used a retrospective cohort study. So we used the ANZHFR registry data, and that's linked to the NDI, or the National Death Index. And we looked at two different outcomes. So first we looked at the descriptive analysis of the group, and then we used a Kaplan-Meier survival curve to get an idea of how mortality tracked over time. So our first outcome was cement use versus 30-day mortality. And for that, we looked at the logistic regression of that group, a Cox proportional hazard modelling, and then we actually did an instrumental analysis as well. With our secondary outcome, we looked at cement use versus 1 year mortality. And for that, we did logistic regression and a Cox's model as well. So when we look at the Kaplan-Meier, so here we have our Kaplan-Meier with survival on the x-axis from 0 to 30 days and survival probability on the y-axis from 90% to 100%. In blue, we have our uncemented cohort and how their survival probability tracked over time versus the cemented in red. And what you can see is that the cemented actually did have a lower survival probability at that 30-day mark, and that was statistically significant with a p-value of 0.0028. Quite concerning. Similarly, when we did our unadjusted regression, and excuse all the numbers on there, I've tried to highlight the ones to look at. If we look at the 30-day mortality, we can see that for cemented we had a mortality rate of 6.49% compared to an uncemented of 4.53%. Similar trend for the one-year mortality with a 22.72% mortality at 1 year for cemented and 17.27% for uncemented. But keep in mind that at this stage we hadn't actually taken into account any covariates that might be contributing to what we were seeing. So when we did actually adjust, so we adjusted for gender, sex, pre-morbid, cognitive state, mobility, and pre-admission residence, we saw that this difference in mortality may be due to some of those covariates. So for our adjusted multivariable logistic regression at 30 days, we had an odds ratio of 1.14 with a p-value of 0.38, so non-significant. And similarly with the adjusted Cox proportional hazards regression, with a hazards ratio of 1.08, we had a p-value of 0.16. Similar conclusions we drawn with the mortality at 1 year. So our adjusted multivariable logistic regression had an odds ratio of 1.19 with a p-value of 0.07, again not significant, and same with the adjusted Cox's proportional hazards regression, hazards ratio of 1.03 with a p-value of 0.68. So lots of analyses in this. We also performed instrumental variable analysis, and when we say I have to give a lot of credit to Prof. Harris on that. So we had, with the odds ratio, the cemented group was 1.00, and that did cross the one. The p-value was less than 0.001 for the test for weak instrument, and that basically meant that hospital preference was a strong predictor of cement use, and therefore it was a suitable instrument to be used for this, effectively showing that this effectively minimised the influence of any unknown covariates in our study. Oh, I went back. So to look at, after looking at those results, I guess discussing what does that all mean. So really what we found was that there was no significant association between mortality and cement use at 30 days or 1 year once adjusted for the covariates. We saw in our group that older patients with a lower function premorbidly, so be some sort of cognitive impairment, requiring some sort of assistance with walking and coming from nursing homes, were more commonly cemented. And when looking at our Kaplan-Meier's, we didn't identify that there was any significant time point in which mortality peaked. So, for example, in other studies, what's been previously seen is in the first 24 hours related to the bone cement implantation syndrome, that mortality did peak in those first 24 hours. We didn't see that in our study. When looking at our study, what were the limitations? So it was retrospective and observational, and that comes with its own limitations. Our clinical judgment of our variables, so things like our ASA grade or our assessing cognitive status, that can change between different clinicians. And we weren't able to assess our data validity for this as part of the ANZ-HFR data set. So strength of the study, so it was a large sample, it was a national cohort, so we used the Australian data sample primarily because we didn't have access to the New Zealand mortality data, but either way, large samples, so that basically eliminated our selection and recall biases and eliminated our patients lost to follow-up. The findings are generalisable to the Australian population, and we had consistent findings across our different analyses performed. The IV analyses also minimised, as I mentioned, any of those unknown co-founders that may have been present in the study. Take-home messages. So no significant association was found between cemented arthroplasty and mortality at 30 days nor at 1 year. So from that conclusion, given the previously established benefits of using cement in arthroplasty, we can conclude from this study that it's safe, it's not going to increase your risk of mortality, and it's an effective means of performing arthroplasty. I would like to acknowledge the Australian Hip Fracture Registry for supplying the data and facilitating that, Prof. Jackie Close, Prof. Ian and Dr. Lara Harvey as my supervisors. And thank you very much for your time today.